So good afternoon, evening, depending on where you sit on that debate, everyone. Thanks for joining us. This is our first Gerontology and Tonic of the 24-25 academic year. I'm standing in for Christoph, who is another member of our ERA committee, to chair this one, as he's joining us a little bit later. So when he does join us, he might take over the chairing for the questions at the end. So welcome to Dr. Dalia Tsimpida, who is a lecturer at the University of Southampton. Before Dalia joined Southampton, she worked at the University of Manchester and Liverpool on hearing public health. Prior to her academic career, she worked for 18 years as a senior research psychologist, where she analysed big data, designed and evaluated behaviour change interventions, and provided expert advice to government departments. Dalia specialises in the social epidemiology and public health aspects of hearing loss, with a particular focus on the links between socioeconomic inequality and hearing loss, as well as the impact of noise on physical and mental health. As a small d deaf person with a hearing loss myself, I am very pleased that Dalia is with us today to discuss her research. So over to you, Dalia.
Thank you so much, Lisa, for your kind introduction, and good afternoon, everyone. It's a real pleasure to be here with you today, and many thanks for the kind invitation. My name is Dalia. I work at the University of Southampton as a lecturer in gerontology. And today's lecture is focused on aging, hearing, and social participation. I'm going to briefly touch the issues of the importance of hearing for healthy aging, the estimates of hearing loss at the population level, and the implications that hearing loss has for integrated care for older people. Starting with the importance of hearing for healthy aging. This is an under-recognized topic, but a few years ago, in 2021, aging and hearing care sectors joined forces to raise awareness of the link between hearing and healthy aging. This was set up by the International Federation on Aging, who has organized since then several initiatives and discussions at a global level to highlight the importance of improving access to hearing care for older adults. Before we proceed, I would like to give you a clearer idea of what we mean by hearing loss, because it is more complex than simply the loss of volume, as many people think. Hearing loss often impacts intelligibility and clarity rather than just amplification. And I wanted to briefly show a 1-minute video to understand the different levels of hearing loss, that is mild, moderate, severe, and profound. And in this video, you will see how a typical restaurant conversation might sound to someone with hearing loss. So let's watch the video together. You've just gained a simulated experience of what hearing loss sounds like. And many of you may believe that your hearing is perfectly fine and you should not be concerned about it at the moment. But what you may not know is that the changes in our hearing health occur slowly over a long period. And these changes can happen faster regardless of your age. If you are around really loud noises without ear protection, or if you are consistently exposed to fairly loud sounds for a long time. So protecting our hearing means that we protect our social sense, as I name it, the sense we use to communicate with others. And it is an important sense because for those not natively deaf or fluent in sign language, it is central to the sharing of ideas and emotions and happenings. I said ideas, emotions, and happenings because hearing health is closely linked to our cognitive, emotional, and behavioral well-being, which is how we think, feel, and behave. And all of these factors affect the quality of life we can have both now and in the future. Historically, hearing loss has largely been conceptualized as an impairment within a biomedical model and managed clinically within an isolated model of care with little consideration of the implications in social participation. However, as you can see in the figure, the WHO classification of functioning and disability provides this framework for how a health condition like hearing loss can be understood within a broader biopsychosocial environmental context. And according to this framework, hearing loss, when viewed as a health condition, can affect both body functions and structures, such as the deterioration in the ear. But not only that, it can also affect related activities with reduced speech understanding, as we saw in the restaurant earlier, and the participation of the individual in society, which is about engaging in employment, receiving education about health issues, attending social events, or receiving health services. So you can understand that hearing loss is a really important public health issue. It is far beyond a sensory impairment because the impact of a hearing loss does not end with a person's ability to hear, as commonly believed. And hearing loss has many physical, cognitive, economic, and emotional consequences and impacts the quality of life, mental health, work, education, family life, communication, and social life. It is the third most common chronic health condition after high blood pressure and arthritis. And according to the global burden of disease, it is the third leading cause of years lived with disability worldwide, following low back pain and headache disorders. And this highlights the substantial impact that has on global health and the significant contributions to disability, particularly among older adults. As you can see on the slide, the consequences extend to health and social care and exert a substantial economic burden. It is estimated that costs the English economy over 25 billion per year through productivity loss and increased unemployment. It is linked to chronic health conditions, including depression and dementia. More than 5 million older adults in England can be affected, and it disrupts education, employment, relationships, and mental health. Regarding the link of hearing loss with mental health in particular, in a recent nationally representative study using data from the English longitudinal study of aging, I provided robust evidence on the causal relationship between hearing loss and depression, identifying a clear socioeconomic pattern over 16 years. The findings revealed that hearing loss affects people differently based on their socioeconomic position, with poorer people facing a disproportionate impact on their quality of life, and people in lower wealth groups face double the risk of developing depression compared to wealthier individuals. And these findings reveal that the mental health burden in disadvantaged populations is exacerbated by hearing health inequalities. This study also showed that the hearing aids can alleviate these mental health impacts, which is very promising in terms of treatment and opportunity to improve mental health. Hearing loss is linked not only with mental health, but also with cardiovascular disease, Alzheimer's and dementia, diabetes, chronic kidney disease, and is linked to threefold risk of falling, and 32% increased hospitalization, and greater risk for mortality. So you can understand that it is linked to multimorbidity in later life, but also makes more difficult the management of co-occurring conditions. So if someone has diabetes and hearing loss, you can understand that receiving results, communicating with health professionals can be even more challenging. And you can imagine how difficult this may be, and people with hearing loss find it difficult to communicate with health providers, and they are left unclear about the condition and the medical instructions after the appointment, which poses significant risks for patient safety, and the difficulties highlights the difficulties in managing chronic health conditions, especially in later life when we have two or three conditions for most older adults. The barriers in communication pose huge challenges, not only for the patients but also for medical professionals. Effective communication in a clinical setting is crucial so as to discuss with a patient with hearing loss their symptoms of a health condition and to be able to do an accurate diagnosis. This is an area where more training is needed for health professionals because many of those ignore how to properly communicate with a person with hearing loss. The problems with communication are also associated with poor adherence to medical treatment, which poses a significant risk in patient safety, especially in polypharmacy. You can understand the errors that may happen reading the tweet on this slide. The fact that 15 sounds like 50 is a flaw in the system that everyone is aware of and no one is acknowledging. That happened to me as well after a telephonic consultation, and I had 15 instead of 50, so you can understand that I got a wrong dosage in my medication. All these issues carry a huge economical impact because the NHS and social care services waste approximately £150 million annually because of missed appointments, extra GP visits to clarify things or discuss again things that people may have not well understood, and increased use of social care. This is an estimation 10 years ago, so I guess that the cost is even higher at the moment. This means that it is really important to understand the magnitude of this neglected public health issue and to understand the national picture of hearing health inequalities. A few years ago, I led the PLACE project, which means the prevalence statistics of hearing loss in England. This stands for the abbreviation. And in this project, I updated hearing loss estimates in England for the first time in 40 years. And unlike previous estimates, this study used data from a national sample from the English longitudinal study of aging, uncovering a much higher prevalence of hearing loss, particularly in regions like the north, with a legacy of noisy industries. The findings revealed that over 5 million people 50 years and older may have disabling hearing loss, which is about 200,000 more people than previous estimates. And notably, we discovered a previously unknown north-south divide, with northern communities experiencing worse hearing outcomes, having equivalent hearing outcomes to those living in the south about 10 years earlier in their life. And as the samples were from people with similar age profiles, both within the same wave and across waves, due to the sampling method in ELSA study, the findings showed and provided surprising evidence that the increasing trend in hearing loss prevalence was not age related, as widely believed, but it is potentially due to social and lifestyle changes and differences among different communities according to the place of residence and many other factors. For example, different occupations, more manual occupations and heavy industries in the north, or different environmental factors that may play a role. In the findings, we saw three distinct patterns. People had worse hearing in northern areas with a higher percentage of the population working in manual occupations, higher deprivation levels, and increased alcohol consumption. And these patterns, occupation, deprivation, and alcohol consumption, make sense as the North has a history of heavy industries since the 1850s. As you can see in the map, which is a map of coal mines in England from 1850s until 1989, when the last mine closed in Durham in the north. The data about the prevalence of hearing loss comes from the survey, the English longitudinal study of aging, and despite being nationally representative, it is not real-world data based on patient records of the population. And due to the importance of hearing for healthy aging, especially in the north of England, where the rates look persistently higher, it is important to monitor the prevalence of hearing loss as we do with the other health conditions at the population level. Today, we completely ignore how many people have a hearing problem in local authorities and integrated care systems, as they have been renamed. And policymakers collect data for people who have vision loss and monitor the changes at the population level for each year and each region in England. But similar data for hearing is lacking. And they also record all those who have diabetes and are referred for eye screening. But unfortunately, those people are not referred for ear screening as well, despite the fact that hearing loss can be a result of diabetes, as was revealed in one of my recent projects here at the University of Southampton. So we don't have, we have no idea of the magnitude of the problem for hearing loss, and this is due to a misunderstanding in the Care Act 2014 that prompted the collection of data for vision loss but not for hearing loss. And at the moment, unfortunately, the hearing health of the population in public health is estimated just by counting the number of older people in each local authority based on data from national statistics, and roughly estimate a percentage of those who may have hearing loss without taking into consideration the actual needs of the population. Furthermore, the accuracy of these estimates has never been validated with real-world data from patient records, yet still determines the local hearing health needs and consequently the resource allocation decisions, which is really important in terms of health policy and public health. For example, in northern areas where people have greater needs, the resource allocation should be equitable in order to cover these needs and be able to have all people who go to the GP complaining about hearing loss to be able to be referred, because the available resources can cover the free hearing aids at the population level. So we understood that it is essential to analyze the data on hearing health problems in a more systematic way, just as we do for other health conditions, for example, diabetes, depression at the population level. And for this reason, to address this gap, I recently led a project that received funding from Research England, and the project aimed to better understand the local hearing health needs by analyzing for the first time big data from English primary care. That was a novel study because it is the first time globally that this estimation is taking place. And as part of the project, I analyzed the hearing data of 2.7 million people living in all 9 local authorities of Cheshire and Merseyside integrated care system. This is one of the 42 integrated care systems in England, and this is close to Liverpool, to give you an idea, because prior to my current position, I was a lecturer in public health at the University of Liverpool. So I ran this project and got access to the real data of all people who are registered on the system. This is a coverage of 98% of all people registered from 2013 to 2022 when I conducted the study, and data from all people who live there and are recorded in a GP. And the results revealed vast inequalities in hearing health, which is not related to the age of the population, as the results were age adjusted in order to see differences in small areas, lower super output areas, which is the small areas that have a population of around 1,500 people, to have comparison and to be able to see what is happening in the area and over time. And we observed distinct clusters of areas with statistically similar values over time, which shows different trends of high, medium, and low increase in hearing loss prevalence. And we can see that all clusters, no matter high, medium, or low rate of increase, were continuously increasing since 2013. And you can see that the gap is widening between the three clusters, which means that inequalities are widening over time. And this means that there are populations who experience a more pronounced decline in hearing health at an accelerated rate compared to other people of the same age. We saw in areas like Halton here, in red, this area had the greatest percentage of a high rate of increase over time. Nearly 40% of this local authority has an increased rate over time, and nearly half of the population, which is about 30,000 people, are living in an area with a high rate of increase. Lastly, I employed an advanced methodology to estimate the projected prevalence of hearing loss over the next 5 years until 2027, based on the continuation of trends observed over the past decade. So if nothing changes, we'll have this forecasting approach to understand how to anticipate the potential trajectory of hearing loss rates and better understand and better prepare in health policy for future challenges in the field of hearing health. And you can see the figure on the right shows the areas where disparities in hearing health are projected to widen significantly, as indicated by the deep blue color. And this emphasizes the critical importance of monitoring in public health intelligence the actual data on the population's hearing health rather than relying on age projections, because all those people have similar comparable age, but in different areas have different prevalence rates. And this is important to monitor these rates because the comorbidities of hearing loss with dementia, with diabetes, with depression should guide tailored and targeted interventions in areas where people need it most. As I mentioned earlier, according to the existing data in the NHS hearing loss data tool, the increase in the number of people with hearing loss is primarily attributed to age demographics. And the current estimate suggests an 18.8% rise in the prevalence of hearing loss for people aged 50 years old and older. But this first percentage is only based on the trends in population demographics and not on actual hearing health needs. But the current data, the actual hearing loss data from primary care records, show an increase between 2015 and 2025 of 56.4% increase, which is alarming actually, because you can understand that not all people with hearing loss are recorded in primary care records. So this is probably an underestimation of the actual increase of hearing loss prevalence at the population level, and it is really alarming considering the link of hearing loss with other conditions in later life and the importance for healthy and inclusive aging. I co-produced this work with policymakers in a Cheshire and Merseyside integrated care system. And you see here the testimonials from one place director from Knowsley, saying that these findings are valuable for policymakers in implementing context-sensitive strategies that effectively address health inequalities. And the Professor Ian Buchan from University of Liverpool, the Associate Vice Chancellor for Innovation, commented that it is encouraging to see contemporaneous estimates of the burden and distribution of hearing loss using integrated care system data. The spatial and social patterns of hearing health are complex and best interpreted alongside knowledge of local contexts and informing integrated policies for aging well. And this leads us to the third part of this presentation, the important implications for integrated care for older people. Promoting healthy aging and addressing age-related challenges is critical to ensuring that older adults can live fulfilling, healthy, and productive lives. The WHO launched the Healthy Aging Framework, a research policy and practice framework aimed at improving healthy aging among the population and supporting the United Nations Decade of Healthy Aging. This framework describes healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. However, older adults often experience challenges achieving optimal levels of mobility and social connectedness due to factors often associated with issues in intrinsic capacity and interaction with the environment. And you may have already heard this term, intrinsic capacity, which refers to all the mental and physical capacities that a person can draw on and includes their ability to walk, think, see, hear, and remember. Hearing, as you can see, is at the core in the sensory domain. And also, it is really important because it is linked with all other domains in terms of depression, in terms of vitality, cognition, balance, because the audiovestibular system is important for our balance. So it's a key sense, a very important sense for healthy and active aging. So protecting and preserving your hearing for life as much as possible means that you can start off strong and well, live well, and age well. And people with progressive hearing loss, if they can take steps to protect their hearing, that can benefit not only themselves, but also those who want to communicate with them, the family, the local community, and the society as a whole, due to the importance of hearing for social participation. You can see here the integrated care for older people. The WHO guidelines propose evidence-based recommendations for healthcare professionals to prevent slow or reverse declines in the physical and mental capacities of older people. So preventable hearing loss can be a tool in order to include this in targeted interventions to improve people's life in later life. The key areas for action on healthy aging include improving measurement, monitoring, and understanding. Second, aligning health services to the older populations they serve. That's why it is important to understand the local context. Developing systems of long-term care and creating age-friendly environments. And in terms of the first priority area, this work I presented to you earlier about the big data analysis included in the written evidence to the UK Parliament for the need to quantify and monitor the severity of hearing loss at the population level and to highlight the importance of the integration of ear and hearing care into national and local health policies, strategies, and plans. And I commented that hearing health indicators should be included in the public health outcomes framework and be systematically collected, analyzed, and interpreted, as it is the case with the other chronic health indicators. This proposal is in line with recommendations by the WHO to determine targets, monitor national trends, and evaluate progress. And we are currently in the phase of assessing and identifying the needs and priorities of the population. And my project was designed to contribute valuable insights in that direction. Shedding light on these key aspects, this project aimed to provide a clearer understanding of the population's requirements and help guide decision-making process effectively. There is ongoing work in progress with the WHO, where I provide guidance for health policy strategies and plans in the WHO Eastern Mediterranean region to inform the systems of 21 countries and territories in this region. This work has greatly influenced policy, leading to the integration of hearing care into health strategies in the UK and globally. I'm working with local policymakers and with policymakers in other integrated care systems to share the know-how, how I did analyze the data, and to provide guidance and in the analysis with the public health staff working in the integrated care systems. And after extensive discussions with the policymakers and the production of a policy brief, the inclusion of hearing loss data collection was among the recommendations in the Chief Medical Officer's annual report, which was published in November 2023. This is a really important step because the inclusion of these as one of the 5 recommendations in such an important document, the annual report on health in an aging society, means that these will be given a priority and will prompt the integrated care systems to include the data collection of hearing loss and systematically collection and to share data on the health and care needs of older adults, including by ethnicity, sex, and other protected characteristics. This is the paper we've written. This is currently under review, but you can download this pre-publication by scanning the QR code on this slide. And yeah, you can get also access to the recording after this presentation. And that's it. I wanted to conclude by highlighting the 3 key messages of my presentation. Hearing loss is a public health issue, not only an audiological issue, because the impact of hearing loss does not end with a person's ability to hear. The current prevalence estimates rely on outdated approaches and data from the 1980s. Therefore, ear and hearing care indicators should be implemented into national and local health policies, strategies, and plans. And ensuring a good hearing health is essential for a healthy aging process and constitutes a vital public health goal, especially for the north of England as a priority, where there has been significant growth in the aging population who live more years in poor health. And I would like to close by showing an engaging video that highlights these messages in an entertaining way. That's it. I would like to acknowledge the funder for the past 7 years who have supported bits of this work, which is still a work in progress. And it's quite difficult to change policy, but thank you so much for the opportunity to present this work in this seminar. And I'm happy to answer any questions you may have. I have also the references I used for this presentation, and I will just stop sharing now.